Okay, today I'm going to dive into a topic that is very near, dear, and top of mind to a lot of healthcare leaders around the country, and that is how do we scale value-based specialty care within a healthcare system? If you are a healthcare leader at a health system or a health plan, and you find that your MSK costs are going higher and higher, and that there's no end in sight, then this presentation is going to be exactly helpful for you. I'm an orthopedic surgeon with over 18 years of value-based care research, over 200 publications and presentations in orthopedics, and 10 years of healthcare system transformation within value-based musculoskeletal care, 3 textbooks, including one on value-based care orthopedics. And so I have lived this pain point. I have worked in systems with this pain point, and we have developed solutions to address this pain point. So I hope that you will find this information helpful. In the next 5 minutes, you're going to learn a few really key things. Number one, what are the 5 key steps to controlling specialty spend? Number two, how do you engage specialists in value-based care and actually keep them engaged and make change that will make them happier so you can ensure lasting specialty value-based care success? So if you look at me as an orthopedic surgeon, how do I get paid and evaluated? Well, I get paid to do surgeries. I don't get paid to make people better. I get paid to do work and do more and more surgeries. And that is the mindset that we have to think about as we engage our specialist providers. If you look at specialty spend and value-based arrangements, what you're going to find is that over 60% of the spend is from the specialist, and yet we take 0% of the financial risk. The risk is either with the plan, the employer, or the provider organization, typically a primary care group. So you're dealing with a group where we get paid to do surgery and we don't get paid to do value-based care and lower costs and improve outcomes. So that is what has to go into the equation when we think about rewiring the specialist brain. And this talk will be showing you how to do that in a way that is meaningful, impactful, and self-sustaining. So there are 5 key ways to scale specialty care in a self-sustaining fashion. Number one is meaningful education. Number two is measuring what matters. Number three, bringing care options upstream. Number four, providing off-ramps after a specialty consultation. A consultation for value-based programs, and 5, re-engage so you can redo this whole loop again in a virtuous cycle. So let's look at education. If you look at most specialists and most orthopedic surgeons, we do not know what value-based care terms are. We don't know what it means. These terms are commonplace for you and your population health and value-based colleagues, but we have no idea what any of them means. Not until did I dive into this value-based journey did I start figuring out what each of these terms mean. So that's what we're dealing with. So you're dealing with a blank slate of education. And the sad part is that most of us don't really care. And the reason is because value-based care right now does not affect our day-to-day. As you saw in that first picture of me going to the operating room, I get paid to do surgery. I don't get paid to think about these kind of the cost containment arrangements and other value-based programs because it doesn't affect my bottom line. And that has to change. And I'll give you an example. For 2 years, I was a course chair for the American Academy of Orthopedic Surgeons Value-Based Care Symposium and course. This is a big course, marquee program, and the AOS is our major provider membership. We had several months of featured promotion to our 39,000 physician members. We featured this at major meetings, major events, a lot of web-based type stuff, digital content type stuff, and the result was we had 20 signups. Right? This is just not impacting day-to-day specialist brainwaves, and so we got to figure out how to make it more meaningful for them. So how do you change this? Well, I think in addition to, advertising and educating in big groups, we need to do small group education. So with your healthcare providers and your orthopedic groups, especially, or other specialists, you need to meet with them one-on-one so they get to know you and you tell them what are the issues facing the organization right now. So if you look at a healthcare system, there are many value-based populations within the healthcare system. It could be the ACO, which is Medicare fee-for-service. It could be Medicare arrangements. It could be their own self-insured employees of the system. And the specialists need to understand what that means. Why is that different from a traditional fee-for-service patient? And how their actions influence, like saying, oh, I'll just get an MRI. Well, that's a big problem if it's unnecessary because it starts this cascade of costs. And really, ultimately, the healthcare system's pockets suffer, right? And so we're all in it together. And so these types of educational sessions that are more intimate will really help drive, especially when you deal with leadership that can then propagate this messaging to the rank and file. Number two, you have to measure what matters. And the first thing is measuring PROMs, patient report outcome measures. We have a ton of videos on PROMs, and we've done a ton of research on PROMs. And basically, these are surveys that are validated that explain what the patient is going through from a physical health, mental health, and pain perspective. If you understand this, you can do better decision making. You can avoid unnecessary surgeries. You can actually get the right treatment to the right person at the right time, which is, of course, value-based care. And so if you're not measuring PROMs on a real-time basis, you're missing an opportunity to help your specialists actually deliver value-based care because we need to know who we do surgery on and who we don't. And if we don't have that tool, we can't do it. There's another type of outcome called PREMs, patient-reported experience measures. These are kind of more satisfaction questionnaires, and there's a lot of them. There's a Net Promoter Score, satisfaction ratings, Press Ganey. I'd say that really the focus should be on those that move the value-based care arrangements. If you're in a value-based care arrangement that is valuing outcomes from an experience perspective, then measure it. Otherwise, it's hard to really kind of motivate specialists to do this if there's no real tangible outcome from that. And finally, cost. That's the other part of the value equation. We need to know our cost. Now, we're getting better at giving scorecards for surgeons and specialists on the costs. I have one now in Epic, my EMR, where after every surgery, I know how much each implant costs, disposable, drape, sheet, sutures, all that stuff. That's great. But what about my population costs? How much surgery am I doing compared to the other person? What are my outcomes compared to non-operative treatment? Again, benchmark against other surgeons. That's what we need to be moving towards. And we're getting there, but we have a ways to go for that, because then I can know if I'm doing too many surgeries, well, is it a population risk assessment perspective? Is it just me just doing too many surgeries? I need to know that. And if you don't tell that to me, I can't fix that. Number three, we need to bring value-based options upstream. And what that means is if you look at the patient continuum from symptoms to surgery, right? Let's say somebody with back pain, they end up with a lumbar fusion. At some point in the process, they've met a specialist, an orthopedic surgeon or a spine surgeon who says, you need surgery. Everything that happens before that specialty consultation is considered upstream care. Everything that happens afterwards is considered downstream care. And so upstream care is what happens before you see the surgeon, because when you see me in the office, there are only two things I can do. I can offer you surgery, or I can tell you I can't help you. Notice that the third option of I'm going to help make you better through a comprehensive, non-operative, multidisciplinary program that really affects your education and activation, that's not an option, right? I don't have time to do that. I've got a 10-minute visit to decide, are you surgical or not? And if you're not surgical, I can't help you. If you are, let's get you scheduled. That is kind of the mindset that we work with as specialists. And we have to understand that upstream interventions are a good way to not have the specialist think and be in a situation of providing two options, which may not be ideal, and helping them with options that they don't even know about. So, for example, an upstream option from a healthcare system perspective is we need to eliminate inappropriate consults. And what does that mean? You should not be seeing an orthopedic surgeon for 2 days of back pain unless you have a red flag sign, or 3 days of shoulder pain, or 5 days of neck pain. And we see too many patients in the office, and this makes us in a tough position because we don't have great options for them. What the healthcare system has to do is invest in better triage. So before you get that specialist visit, how can we get you to the right place? Maybe it's an advanced practice provider, a PA, an NP, a primary care clinic, whatever it is, weight loss clinic. And that is where the healthcare system can triage better. And also this goes hand in hand with limiting open access. Open access is great because patients can get in and have access to care, but we don't want them going down specialty care before they're ready. And I think limiting that or putting guardrails or safeguards around it is really important for healthcare systems to do to in an upstream way to minimize unnecessary consultations. The other thing is, as the system invests in preventative care programs, they need to be delivered and deployed upstream. So, for example, if the health system has a partnership with the health plan, the health plan can help centralize some of these programs through outreach before a specialist visit is done. And that's where something like Protera Health, like our company, can do. Maybe the healthcare system has their own programs that are provider-driven that they can route to. And then also, if patients are having trouble getting into preventative programs, physical therapy, for example, weight loss, all those things, the healthcare system needs to augment that access, because what's going to happen is you're going to pay for it down the road in a much worse way. Now let's talk about off-ramps. This is after the patient has already seen a specialist. Now, specialist doesn't have a lot of options, but if you help a specialist, you can get the patient into the right program. So, for example, if I'm giving a patient a physical therapy prescription and an option pops up that this patient is in a value-based arrangement and would benefit from an integrated practice unit or a multidisciplinary program that I can route them to, make it easy. Let me click yes right then and there, rather than having to figure out where that program exists. Make some best practice advisory alerts to help guide referrals. So let's say an MRI is being ordered that doesn't need to. Well, maybe I can route them to those value-based programs, again, like Protera or any program that the healthcare system is doing. We talked about this before, but have rescue efforts. So if I put a prescription in for physical therapy and 30 days go by, that patient doesn't get an appointment, figure out what's going on, call the patient and get them into therapy how it can be. Maybe they need a digital program. Maybe they need an after-hours program that works with their work schedule. Help them, because, again, you're going to pay for it down the road. And so it's up to you as a healthcare system and leader to guide them to the right spots. And then finally, number 5, you have to re-engage. Now, I mentioned earlier, a lot of specialists rank and file don't really care about value-based care. It's because we're not impacted by a day-to-day basis, but there are a lot of orthopedic leaders and specialists that do care about this topic, that want to make a change. And even though we are not thinking about value-based care day to day, most specialists, the overwhelming majority of specialists want to do the right thing. We don't want to do surgery on people that don't need it. And so you're going to have a receptive audience when you talk about value-based principles of right care, right time, right place. Um, and also, we need to get continued education, right? Like I told you, that map of terms, acronyms, we don't know what those mean. You have to educate us in both larger group settings, smaller group settings, and so that we can understand what that means when you have an at-risk population. Is that at risk medically, surgically, or from a financial perspective, which it usually refers to? We need to see that data on cost and performance outcomes so that we can benchmark ourselves and do better from that. And then all those tools you invested, such as the upstream triage, will help make our experience better and help us buy in more because you're making our office experience better. We don't want to see people with 2 days of pain that don't need surgery. We want to see people that actually could benefit from our skills, and that would be a more appropriate patient. So, as discussed, there are 5 things that you can do as a healthcare leader to boost value-based specialty care. And number 1, in summary, educate. 2, measure what matters. Number 3, bring it upstream. Number 4, easy off ramps for specialists. And then number 5, re-engage to create a virtuous loop. I hope this was helpful for you. Please feel free to reach out to us anytime, and we'll be happy to discuss further and discuss how we help health plans and health systems with these populations as well. Hope you all have a great day.